Hi, I'm Soumya from VS Hospitals again. It's such a pleasure to have all of you again back. And today's topic is going to be again a very different topic than what we have spoken all these days. So it's going to be an awareness. You would call it as an awareness. You would call it as an information. So we have our head and neck oncosurgeon, Dr. Shubhra Chauhan, who will be joining us. So this is about the 3D reconstruction of the oral cancers that we are going to talk about. And I'm sure the 3D printing and reconstruction in oral cancers is something which is a new technology. And there's a lot more that we really need to understand and what it is, because it enhances the quality of life for many. So sharing this information is going to be very, very helpful, I presume. So regarding this, before we could get into this is something related to head and neck. So I have another interesting information also, that we are launching the head and neck unit, because all these years in VS, we used to do it as a common practice, and we used to treat all head and neck cancers and other cancers as well as a part of a treatment. But now we are launching it as a separate unit, where we do have senior most doctors who are part of it, and along with it, the entire team who will be working along to guide us, help us, treat us, and help us have a great quality of life when it comes to oral cancers. So let's welcome Dr. Shubhra Chauhan, who's a consultant in VS Hospital as a head and neck oncosurgeon, who has given an excellent patient outcome, who's been so friendly, and who's been helping a lot of patients, to get a right treatment and right diagnosis on a right time, which is very, very important. So we welcome you, Dr. Shubhra.
Thank you. Thank you so much, Soumya, for the introduction.
Yes. So there are questions that, because this concept itself, the 3D printing, reconstruction in oral cancer, the name itself is very interesting. So what do you do when you say it's reconstruction in oral cancer?
So very important. See, generally we as oncosurgeons are always targeting our talks, lectures, awareness on, if I say, what are the early signs and symptoms? How do you diagnose yourself on your self-examination? And generally when we go in for camps also, it's always early detection or trying to diagnose the patient.
Right.
But we never actually give the, I won't say as a doctor, we don't give importance, but we lack the importance of giving this second part of the surgery, that is reconstruction information to the patient. And that is the reason I thought talking on this will be more important, because I have done my bit. Even with the hospital, I have given these small talks about early detection in oral cancer, what happens when you get diagnosed, not to get scared, what treatment has to undergo, what are the side effects of surgery, radiation therapy, chemotherapy, and stuff like that. So what is reconstruction? If we just in broad, what we are trying to tell is that when we are doing a surgical resection, that means when we are removing something from your oral cavity, from your mouth, naturally there will be a gap or a gadha or some space which is created, which has to be given this kind of same form and function, I can say, at least near normal. I can't say exactly normal, but at least near normal form and function from what was available over there, because we have removed a part. And that concept is known as reconstruction. So that is what we mean by reconstruction in oral cancer.
Wow, that's good. Because I'm sure that itself creates a lot of trauma with people, that they will lose the shape of their face, the looks and all that, that trauma itself actually pulls them down, which I would see, because we've seen a lot of patients coming up with these kind of doubts when they talk about all this. So reconstruction is something which will be very helpful, and that is nice. So how do you do the reconstruction, doctor?
So this is not something which is a new or anything concept. Reconstruction totally not. From time immemorial, from the time cancer has been starting in treatment by resection, I mean by surgical resection, reconstruction has been there. That means when we remove something, we have to place it there, of course. So what we generally used to do previously, or if we go a few decades back, even before I started my training, I can say, that time we used to generally do reconstruction of filling the gap with something which is nearby. We call it local reconstruction, taking tissues from nearby, maybe from the chin, from the cheek, from the forehead, from the scalp, or from the neck, and then patching it inside. And then when the defects were bigger, generally reconstruction primarily is more important when the patient drops in late. I mean the stage is higher. We are no more in the era that you can't treat stage 3, you can't treat stage 4. No, we are not. Even stage 4 cancer is very well treated in oral cavity if it is operable, or if we can undergo some chemotherapy followed by surgery. So these will create large defects. So these were also being reconstructed before. It was not that they weren't. But then we used to use something known as regional flaps, I will say. So from local, we had to do regional for larger, bigger defects. Okay. So that was generally taken from the chest or from the back. Okay. But what has further developed into it was the microvascular reconstruction. And I would say that today era, the gold standard for reconstruction, if some patient asks me, doctor, what is the gold standard? What is the best you can do for getting us the similar kind of face looks? As you rightly pointed out, the trauma. See, unlike other cancers of the body, the head and neck cancer is one subsite which faces this issue very, very, very practical problem it is. Yes. Not just the looks, but it's even the function, it's the form, both. It's not just the aesthetics, not just the form, even the function, both are affected. So then came in microvascular reconstruction. And that is what has changed the whole ball game, I should say.
I was about to ask you about that. So what is that microvascular reconstruction?
So actually what is happening in this is from local to regional, what was the main difference was that the tissue was shifted from one place and to the oral cavity or to the mouth, but it used to be attached to from the tissue where it was being taken off. I mean that if you're taking a tissue from the chin, from the cheek, or from the chest, the other end of the tissue which is being taken will still be attached to the part where it is being taken off. Got it. What changed in microvascular is the tissue which was being taken from your part of the body. It is from yourself, on your body only. Okay. So it's not that somebody else's tissue you're putting. Right. That tissue or the bone with the muscle and the skin, anything which was being taken, it is taken along with its artery and its vein. All of us know that there is something known as blood supply to all our parts, which is supplied by the artery, and the blood which is withdrawn from that area by the vein. So now when we are taking this tissue, it is taken along with the artery and the vein, which is supplying that area of the body. Okay. Because these areas are not going to cause a major deficit to the patient. So when you take this tissue out, now you have lot of flexibility as we as surgeons, the reconstructive surgeon, the plastic surgeon, the maxillofacial surgeon, they have a lot of play to it, and we can make the present form of that much better than what was being like it was like pulling something and trying to pack an area. Now we are able to get a free way. It's a free tissue. It's in our hand. Now we can modify, shape, everything we can do and stitch it around with the correct shape. And another big advantage we got in this that we could also take bone along with the soft tissue. So if somebody is getting a bone cut done in the mandible, that means the lower jaw, or maxilla, that is the upper jaw. When a bone is being removed, we are replacing it by bone and not just by soft tissue.
Right. So doctor, that is very helpful. So you've given us a bit of a hope, for our patients and so on. So what is the advantage over the older techniques?
So primarily, this is the key point over here is that we have a lot of play to it. Before it's not that it's a bad concept. I will not at all say. We still sometimes have to use that concept for some, reconstruction per se has to be done in some form or the other. So if sometimes we land up with a patient who is medically compromised, or a patient who cannot undergo general anesthesia for a very long period of time, or there is sometimes in patients where the, the stage of the disease is such that we are going in for a palliative resection. In that case, we will be doing reconstruction with a previous technique, that is a regional flap. So it's not a disadvantage of doing that. The only thing what I'm trying to say, the extra advantage, the edge which we are getting with microvascular is that we are able to get a better form, better pliability, better flexibility of filling the gap compared to our previous technique.
Oh, okay. That is nice. So if it is advantageous, is there any problem the patient will face due to it?
Yeah. So see, a surgery is a surgery. So you are going to land up with the scar. So I will not say that it's like we are doing something without a scar, or there is nothing going to happen at the area where we are going to take it. But the key point our patients should understand is that the tissue which is taken from somewhere else, like I'll just give you the direct example, is generally we take, when the tissue amount is small, we take it from the hand, which is on the inner aspect. And generally we take it from the non-dominant side, that is the left hand if the patient is right-handed, and the right hand if the patient is left-handed. Similarly, if the tissue amount is needed large, generally we take it from the thigh or the abdomen. You're already seeing these are hidden areas, understanding. And if the patient needs bone along with the tissue, like as I told, sometimes the jaw is being cut, upper or lower. In that case, we generally take it from the leg. So if the key point about what I was trying to tell you is that these areas where we are taking tissue will create a deficit. Of course, it will create a defect over there. I'm not denying the fact. But the point is that they are being taken from areas which are non-critical. I mean, even after taking out the tissue from there, the patient is not going to land up any life-threatening morbidity. Now, morbidity means the patient is not going to land up with any life-threatening problem or side effect of that. The patient can easily survive and easily lead his normal life, I should say, exactly normal life, though some tissue has been taken out from his body from somewhere else and put in the mouth. Correct. So it is an advantage. You get a scar, but these are the only thing is you get a big scar over there. Like here you get a skin graft done. Okay. Sometimes we in the leg we take, so they put a skin graft. Now one more thing, a lot of patients have the same very doubt. You're going to take out a bone piece from, especially when it comes to tissue, they understand we will patch it up with the skin graft and they understand it very well because skin grafts are being used from trauma to all surgeries. But the moment we say bone being cut, they get panicked. How will I walk? How will I sit? How will I run? So my point to communicate is that though bone is being taken out, it is a non-dominant bone of your body and it's called fibula. So when you take that bone out, it's not going to create a problem that you cannot walk. The patient is actually, in our center, we are ambulating the patient almost on the second or the third post-op day itself. That means in the ICU itself, we start ambulating the patient. So you can understand by the time the patient gets discharged, he should be almost walking near normally, and less than a month, he's walking normally. Even the patient can play. If he is a sports person, can almost play. So it's not something which causes a bigger deficit. You get a deficit which is easily acceptable to your life for such a big defect which is created.
Well, doctor, thank you so much. That is such a lovely information you've given, because those are all the common fears that the patients come across on a daily basis. So when you're talking about the the fibula part that you'll be, the bone part that we were talking about, you're talking about the graft and all that. So I'm sure there will be a lot of surgeons who will be involved in it. So how many specialists are actually involved in this?
Yeah, so it is very important for the patient to understand that it is not a single person doing all this. It is a team approach, 100%. Correct. So generally as oncosurgeons, we are more towards the head end, doing the resection, neck dissection part of it. And then we have our reconstructive surgeons, which are again a team of 2 to 3 people, depending on which flap we are taking, who the reconstructive surgeon will compromise sometimes of a plastic surgeon, maxillo-facial surgeon, and another sometimes even of the oncosurgeons combined with it. And then they are doing the flap. What I mean by team approach, 2-team approach is that we generally tend to operate simultaneously. And that also saves in time. That means when we are operating on the upper end of the body, we will be operating either down on the hand, the thigh or the leg accordingly, so that the patient saves time on it. And once this area is cleared, the reconstructive surgeon along with his assistants quickly shifts over upwards and the other people start closing the other hand. So it's like a continuous, continuous team approach which is working out. So that is the reason around, if you see the 2 primary surgeons, that is a resection surgeon and a reconstructive surgeon, other than that, there'll be a team of total around 5 to 6 surgeons will be operating.
Oh, that is a huge group.
Yes.
So I'm sure. So that is how, it's understood that patient will be benefited also,
yes.
All these doctors in place. So now when it comes to the reconstruction part, when all these surgeons are involved, the time that is involved, and the way patients' outcome comes in after the surgery. So I'm sure the cost is also equally a question for people. So is it costly? Is reconstruction costly? And what is the age group that it can be done? Is there any restriction?
Very pertinent point from patient point of view. So what happens is, in addition, when we turn towards, I will not say reconstruction is a costly affair, because as I told you, we have a lot of other ways we reconstruct. Sometimes when the defect is small, we can really do away with the local flap. It's not a bad option, as I previously also told you. Sometimes we don't unnecessarily want, why should we unnecessarily make a deficit for a patient when something can be done regionally or locally? So reconstruction per se is not a costly affair. It is a part of the surgery. It is not a separate surgery. Yes, one more important point I want to, a lot of my patients ask me, doctor, this will be done. So when will the flap be put? So the first thing I want to communicate is it's a combined surgery. You cannot remove and leave yourself open. We have to close it there. So reconstruction per se is not, it's a part of the surgery. But yes, when we come in vogue of, as I told you, the gold standard, that is a microvascular reconstruction. Why the cost additional comes is, one is because of the timing, which slightly increases in it. And second is these type of flaps need very close monitoring, in the sense that they need to be monitored in ICU for 2 or 3 days sometimes, depending on the criticality of the flap. And that is the reason that the sum of the post-op cost of the patient slightly raises. Yes. As far as age is concerned, age is a number, in the sense that it's not about the age of the patient, but the fitness of the patient. Why, I will tell you also. Because when you do the microvascular reconstruction, what happens is these patients, as I told you, will need an ICU stay for longer, and sometimes need to be ventilated. That is, we ourselves are telling the anesthetist to ventilate the patient overnight in order to stabilize the flap. Because as I told you in this, there was an artery and a vein, if you remember. When it is put in the area that is joined to the neck artery and vein, that means this flap was taken with an artery and a vein. It was put in place. The bone was placed in place, and the artery of the vein of the flap was joined to the neck, which is the existing artery and vein. And then the blood supply to the flap starts immediately. It is that fraction of the second, the moment the reconstructive surgeon anastomoses it, that means joins them, the flap is already viable, or is it's working. So that is the reason that has to be checked. Is it working or not working, like that? So that has to be done in an ICU setting, and that is that takes and patient has to be ventilated. So you are understanding, it's a long hour surgery, patient being ventilated, has to stay in ICU. So fitness of any age patient, sometimes even an 80-year-old patient may be fit, and a 50-year-old patient may not be fit if he is having too many comorbidities. So practically, primarily, if the patient is fit for an anesthesia for such long and ventilation, we take him or her for primary reconstruction with microvascular. But if we are unable to do that, as I told, we always have a regional flap, and we have our local flap in our hand to reconstruct the patient. So the patient will be reconstructed this way or that. That's
right. Thank you so much, doctor. That was helpful. So when it comes to the recovery time that is involved, so what would be the recovery time for the patient?
Yeah. So you come in, I will just put the phrase, you come in early, you go home early. You come in at a later stage, you go home at a little later. So it is very simple. That's the key for our, as oncosurgeons, we keep stressing on early detection, and especially in oral cavity, because this is an area where it is self-examined by the patient itself. We don't need any major expertise of a doctor or a nurse to diagnose it, to be very true. And you have a lot of these self-examination videos also nowadays. So you come in early, you go home early. I mean by saying that you may not have an ICU stay at all. You may not need a flap at all. Forget again reconstruction thing. But yeah, when you come in at the later stage, and as I'm saying, generally there will be a week to 10 days stay if you're going. That is the hospital part I'm saying, and invariably the patient will take a little more longer once he or she reaches home to recover from the whole complex operation. So you can take another week or two for that. So there is going to be a time gap. You can't expect that the surgery, it's not a surgery where it is done today and by the third or the fourth day the patient is totally fit to do everything. What I'm trying to mean by taking so much time is that because it's the point that patient initially is not being fed by mouth, because we have done the surgery in the mouth only. So there is a tube which is put in place through the nose for the feeding, and that will take some more time to come out till the healing happens and the patient is able to eat. Both the things. One, the healing should happen, and second is the patient should be able to eat, drink at least a near normal food. May not be a proper solid food, but at least a near normal food. So then that case, that recovery time. So you can say around 3 weeks. Sometimes for a very complex operation, it takes a month to recover.
Okay, so that was very helpful. So viewers, very important, as doctor said, you come in early, you go early. So
you go in
late, then you go late. So early detection again comes in here. So awareness is very, very important, and don't wait for something big to happen, and easily diagnose it at an early stage. So that is one very important information doctor has given. So is it a new technology, and what are all the advancements that are happening right now, doctor, in this?
So that's primarily our today we both sat here primarily for. So microvascular reconstruction itself is a gold standard. I totally agree. And it has been happening. It's not something, oh, wow, you're doing it over here first time and all. No, it's not like that. It's been happening. We have also been doing since quite long. So what eventually has happened is that the development happened more in terms of the bony reconstruction. Okay. What happens is when the bone is taken, to fix the bone, to cut the bone, to shape, it takes quite a bit of time. Plus to match up with the original of the patient. What I'm saying is, see, the primary idea of the reconstruction is to get the patient near normal. I told you, of course, not perfectly normal, but near normal. So the idea was that it could come only through the 3D printing. So with 3D printing, we could reach the next stage in bony reconstruction, I should say. And it also helped us in rehabilitating the patient, getting rehabilitating after the surgery better. So that is what the new thing you can, if you want to say the in thing or the new thing in head and neck reconstruction is 3D printing.
Okay, so what is 3D printing and how does it add and benefit to?
Yeah, so see what happens in this is that the surgical aspect as well as the cutting aspect, the resection aspect doesn't change. But what the patient does is pre-surgery. Generally, we do scans for these patients. Right. So when we are planning a 3D for a patient, 3D printing for a patient, it is generally done in majority of the patients who are having bony deficit. As I told you, either the lower jaw is being cut or the upper jaw is being cut. And we are going to give bone-to-bone reconstruction. Instead of that bone, we are going to put another bone. So what happens in this is once the patient is doing the scan, a specific format is told by us, by the surgeon to the patient, in which the scan has to be done. Okay. And once the patient reports to us with that scan in the CD, this is uploaded and sent to the technical team who do the printing. Okay. They again upload it into their software and they print the present situation of the patient. Print it in the computer, I mean. Print is not printing on a paper, I mean. Right. It's in the print in the computer, where what we see is we get a 3D model of the present situation. That means if he or she has a cancer in the jaw, let me give an example, and there is the cancer of the jaw has gone into the bone and it has eaten away a part of the bone, that part will get as a 3-dimensional mandible model will come on the computer. Now this is communicated to the surgeon again, to the resective surgeon again, and asked what you want to do from where you're going to cut. So we communicate then the cuts where we are going to give the osteotomy or the cuts for this part of the tumor. Okay. And they then plan that cut is done in the computer again. Okay. Once the cut is done, you can understand there is a gap happening in the jaw. Okay. That jaw has to be filled up with the fibula bone. That is a bone, suppose a fibula bone. Otherwise, bone is also taken from the hip and sometimes even from the scapula back. Okay. Majority times we do fibula. So if you take the bone from the leg, that they make another model of that in the computer and they fix it in the computer. Okay. You understand it? There was a gap which we created. We told them where to create the gap. That gap is created and they take the bone from the fibula in the computer and they fix it there. And sometimes when the patient comes at a very high stage, this jaw may be totally destroyed. Okay. In that case, what happens is once we give this cut, when we are doing a freehand surgery like before, and when the 3D printing was not in vogue, that time we had to think, arbitrarily calculate and do the surgery. But here in the computer, we can do the exact measurement. Okay, 3 centimeter cut, 2.5 centimeter cut, 6 centimeter cut. They exactly measure those areas. The angle, if you see, is very important for our jawline. The angle is exactly measured from the opposite side. That means they mirror the normal side to the destructed side. Okay. And they give a proper angulation to that jaw. Okay. And then they make a model. And that model is again printed to us and comes in our hand for our calculation. Like we know which calculation, how much bone has to be poured, what centimeter it is, at what angulation is it. We have gone a step further in this also. What they also started giving us is cutting guides. Cutting guides are for the surgeon. Of course, for patients, it may not be important. But what it helps us do is, for the patient information, I can tell you is that it helps us to cut it at the exact same level where the cut is going and what angle it is going in the jaw, the same angle and the same level it is cut in the leg bone. So you're understanding, if it is a 30-degree angle at 3 centimeter, this thing, it will be exact same in the
accurate readings.
Accuracy. Yes. So the bone accuracy has increased by leaps and bounds, I should say, with 3D printing.
Wow, wonderfully you have explained us about these advancements. I mean, that is really amazing. So doctor, how does it, what is the additional cost added in due to this? And is it safe? is another question I wanted to ask you.
So these materials are, see, the additional cost, if you're just doing a printing, guides and all, is not going to be much for the cost of the microvascular flap, maybe 8 to 10,000, maximum 15,000, which gets added because it's the planning and the part.
Yeah.
And these materials are such that they don't go into the patient forever. These are materials, the models are primarily given to us before surgery for our planning. Okay. And I also told you something about known as guides, which are used by us for cutting the bone and all. They are in biocompatible, they are biocompatible material, which can be autoclaved. Autoclaved in the sense, they are materials which can be sterilized before surgery, but they don't go into the patient at all. So don't worry about it. The only additional thing which has happened is that nowadays we are even not just printing the model, but we are even printing the plate. That means the plate which was custom made, we call it stock plates. Before, we can even print the plate of the patient to the exact same shape and fix it. So we don't have to even waste time in pre-bending, making the shape with the, because they will print again. So that material needs to be biocompatible, and it is being done with titanium. It is the same material which is being used from ages for fracture, leg, hand, face. We have been using it as plates and screws. The same material is being used. So it is 100% safe. So you don't have to really worry about that part of it at all.
Nice. So 3D printing, there's so much that has saved everybody's
yes,
time.
Yes, it has come in, and now it's being used very commonly.
Yeah.
Like if I say 2 years, 3 years back, we were not using it so easily, but now there are a lot of centers and who have started working medically. And another thing to be added is we from BS Hospital, we are working with the center where this printing is done for only medical grade. So there is a difference in that is because the machine which prints these plates for the patients should not be used for printing titanium for any other purpose. I mean the commercial purpose, like aircraft part or some machinery part.
Correct.
So we are procuring it from a place where they are certified to print only for medical grade. So that makes it more safer for us, our patients
nice.
also.
I know that is an assurance, definitely. So it's very nice. So what do a patient lose or gain through this facial reconstruction?
So there is only to lose if you don't do reconstruction, I can say, unless you have come in early. There's everything to gain. So you have to undergo. And if a patient is fit, I always, and if the lesion is big, of course, I always vouch for microvascular reconstruction for this reason. It's not that I don't do regional reconstruction, but I vouch it for, because see, there was a time where we used to treat cancer patients for curing them. And quality of life, that you QOL we say it, or patients enhancement of life was not given so much importance. Right. But now our aim is not just to cure it. What is the use of a cured patient sitting at home 24/7, unable to even meet his or her own relative or go for work? So the idea is to go to a level that we are able to reconstruct not just the patient for sitting at home, but if it's a young person, he or she should be able to go at least for his normal regular activities tomorrow. And sometimes, I should not say sometimes, but majority of times it happens that these patients are breadwinners of the family. And until unless even the time period where we are doing the treatment, which takes, especially for advanced cases after the surgery, radiation, it takes around 3 months totally. They are unable to go back. If they are not able to go back to work, or they feel shy about it, or they feel conscious about it, it creates a lot of setback. So reconstruction has to be done, and if done in the best form, it helps us. And actually, we are not just the patient, even the doctor is happy, to see the patient going back to his regular activity. Right. So I actually say, when my patients come with the odd complaints, doctor, this lip is slightly tilted here, or there is one thread hanging here, I have little sensation problem here. So when they're giving me all these odd kind of complaints, when they come on 6 months, 1 year, 2 years follow, I'm very happy, Jim. I'm like, okay, you are living such a normal life that even small aesthetic issues are becoming big issues for you now. Because that means he is a cured patient who is trying to lead a normal life. And rather than a patient coming, sitting with a depressed look over there. So generally a complaining patient is a better patient, I feel sometimes.
So that's nice. So in addition to this, is there any other additional rehabilitation that is needed for them by any chance?
Yes, very pertinent, because people should not get the idea that, oh, they're doing 3D printing, they're putting bones, soft tissue, skin, flap, everything, I am done. No, it doesn't work like this at all. As I told you, the recovery time itself in hospital itself, it takes around 10 days, approximately a week to 10 days. And post-op rehabilitation is a must and very important. I mean that, as I just mentioned to you a few minutes back, that the patient eats the food initially by the tube. That is a tube feed. We call it Ryle's tube feeding. That is a nose tube. And slowly, as the patient gets rehabilitated. Now, what is rehabilitation means? We are trying to make the patient speak, eat normally. So we sometimes they have to work with a speech and swallowing pathologist who helps them to get the speech as normal as possible. Sometimes they are unable to take the normal diet because, you lose a lot of teeth when you lose both. So that time they have to be rehabilitated to how to use only the normal side, how to change their diet. So these are rehab. It's like relearning to eat and speak. That is one thing. And the next level of rehabilitation is, and of course, physiotherapy, because for the hand, the leg, all these are involved. And the next level is even dentally rehabilitating them. That means we are not just putting the bone, the plate and all, just to put it there to give the form, but also for function, as I told you. So form is the primary aim. And the second aim is to give function to them. That means we try to even rehabilitate by putting them implants if possible. Nowadays, the 3D printed plates are coming with slots, I can say, for understanding or holes or slots in them. These plates, in these slots, after some time, we can even put the implant and the dental implant, and then the teeth over it. So the the side which is non-functional, which was only giving form or shape to the face, will also be functionally rehabilitated, where the patient can even start eating and chewing over there. Okay. So that is, I can say, the additional rehabilitation, which takes a little longer after the surgery and has to be in place slowly and finished.
So that was very helpful and informative, Doctor. So what is the take-home message you like to give to our viewers right now?
Take-home message as a cancer surgeon always will be, please be aware of your signs and symptoms. Though I'm today talking about printing and reconstruction, it is, I will be more than happy if I can treat you at an early stage where I don't have to reconstruct, actually speaking. So the take-home message always will be, please be aware of your signs and symptoms. That is, all of us know that a small ulcer, a red white lesion in the mouth, any change in voice, any difficulty in swallowing, or cough which is not persisting. So anything which is prolonged, see, don't jump if it's a day or two old, but something which is getting prolonged for more than 2 to 3 weeks, please visit the specialist immediately. Only then this 3D printing and reconstruction will not be needed for you rather than being needed for you.
Agreed. Thank you, Doctor. Thank you for your time. Thank you for joining with us. And viewers, this is something very important. So let's not lose hope in terms of, first thing, as Doctor said, early detection, be cautious about the symptoms, and watch out. You start loving your body. So start watching out for what is happening with yourself first. So not only that, but if you at one stage feel, that, you are detected with that, then don't worry, because as Doctor said, there's so many advancements in the treatment. There's so much of reassurance the doctor has explained to us in terms of 3D printing. There are various technologies that they have been using to treat. Okay, so for you to at least have a near normal life. So I'm sure that we have an excellent team who can help you out. So reach out to us if you would like to, have any consultation or any help. Thank you, Doctor. Thanks for joining with us. Thanks for your time. Thank you, viewers. So I'll catch you up again. Yes, thank you. So thank you so much, viewers. I'll catch you up again next week, between 8 to 8:30 again. With a different doctor, with a lot of other questions and a lot of other doubts, and interesting topic again. Thank you. Thank you for joining us.
Thank you.